First of all, I'd like to invite Dr. Stikopu. She'll be enlightening us with the indirect signs for the screening of malformations of cortical development. Yes.
All right, thank you very much. Okay, so MCD. So I would like to talk about the indirect signs of the MCD. The actually, the in humans, you can see this is the stage, the first stage and the second stage of the migration. And here you can see there's several zones, the ventricular zone, subventricular zone, and intermediate zone, and the subplate and cortical plate. As Professor Yamada already, that talked about that. And there are several layers in the brain. And in a nutshell, the migration is like this. The neuronal cells are born in the ventricular and subventricular zones, and they are migrating to the cortex. And that is the inside-out manner. And here you can see this is the ultrasound picture, and you can see the subventricular zone and the intermediate zone, and you can see the border between the subplate and the intermediate zone like this. And here the subventricular zone, a proliferation occurs, and then from there to the cortical plate, the migration occurs. And here you can see the development of the brain. And here, this is 20 weeks, and this is a 9 months. And you can see, that there's no gyration here. And however, after the 9 months, that you can see the gyration more and more. And by the ultrasound, this is between 13 and 21 weeks of gestation, and you can see still until 21 weeks of gestation, you cannot see the gyrification. And this is from 23 to 30 weeks of gestation. And here, the 29, after 28 weeks of gestation, it is much more obvious to see the gyrification. And now this is a 20 weeks baby, and if this brain is going to develop normally or going to the MCD, who knows. However, as I told you, the gyrification is very obvious, conspicuous, in the late pregnancy. Therefore, for the screening of the MCD, around the 20 weeks of gestation is our challenging. Of course, you have to measure the BPD and HC, you can measure the brain size, and macrocephaly and microcephaly can have the possibility of the MCD. And also you can see the symmetry. If there's a asymmetrical structure of the brain, you have to look at the brain more in detail. And abnormal early gyrification, this is the 18 weeks of gestation and 20 weeks of gestation. You can see the abnormal gyrification. Of course, that this is not the indirect sign. This is a direct sign. And also, the irregular ventricular wall like this. And because, the subventricular zone, the proliferation of the neural cells, they are born inside the subventricular zone. Therefore, if you look at the irregular surface of the ventricular wall, you have to observe more. And ganglionic eminence, some of the lecturers already talked about the ganglionic eminence. And also, today, Dr. Christian Mitter told about the gangrenic eminence. And here you can see the 19 weeks, 18 weeks, and 19 weeks of gestation. You can see the cystic area here. And this is this might be the cavitation inside of the remnant gangrenic eminence. Now, the more indirect sign of MCD, I would like to talk about the Sylvian fissure and the medullary veins and Katia line. Now, this is a West. Now, this is not mine. um, and I would like to talk about the West of the brain. Okay, and that is the Sylvian fissure. And the Sylvian fissure, this is a changing appearance of the Sylvian fissure. And 18 weeks, 21 weeks, and 25 weeks, and 30 weeks of gestation. The shallow Sylvian fissure is going to the deeper and deeper, right? And we measure the Sylvian fissure angle. The right and the left Sylvian fissure angle were measured between the horizontal reference line and two lines drawing along the right and left upper sides of the Sylvian fissure. And then we had the data of like this, the Sylvian fissure angle is 0 degrees. That is when the Sylvian fissure is rectangular, is at 25 weeks. So it is a very, easy to remember 25 weeks. And most of the cases, of the MCD, Sylvian fissure angles were larger than the 90 percentile of the normal reference. So now you can notice that abnormal Sylvian fissure here in the MCD cases at 25 weeks of gestation compared to the normal case. And this is the FGR baby, IUGR baby, who is referred to my institute. And if you look at the image, most probably, you may say that Sylvian fissure is rectangle, so this is a 25 weeks of gestation, right? However, this is a 29 weeks of gestation, and it means, obviously this case is the 4-week delayed Sylvian fissure. So this is a 13q microdeletion syndrome baby. And the other one, this is the abnormal, the low set ear and micrognathia. And here it looks normal, the brain. However, I measure the Sylvian fissure angle, and it is almost, this is a little bit out of the reference. And then I look at the baby 19, 20, 21 weeks of gestation. And then what happened, those are the normal reference. And here you can see the Sylvian fissure angle didn't change. And this case was the FOXC2 gene variant. And this is very abnormal, and the patient terminated the pregnancy. So the Sylvian fissure observation is significantly helpful for the making diagnosis of the MCD during the mid-gestation. And again, Sylvian fissure developing according to the gestational age. And we observed all fetuses by transvaginal neurosonography with or without brain abnormalities in my institute. Now, that we have such kind of case, the case A is like this, that this is going to abnormal Sylvian fissure angle, but going back to normal. And the exome sequencing was normal, and there's no other abnormalities, that we are going to follow up this baby. And sometimes, that we have like this, the normal Sylvian fissure, but, at 30 weeks of gestation, it is out of the reference. Sometimes it happens, so that we have to think about the brain development, the postnatal neuronal development. Now, why transvaginal neurosonography is desirable, that is because the bilateral Sylvian fissure are visible in a single plane. And also the asymmetrical brain structure is obviously recognizable. And here you can see this is a very asymmetrical structure of the Sylvian fissure. And here you can see this is a double Sylvius the structure. You know, this is it looks normal here, this side, but here you can see the double Sylvius. So it happens. So, you know, you have to do the transcontinental the 3D ultrasound approach. And the reason for the transvaginal 3D neurosinal, because you know the Sylvian fissure observation is a brain sensitive. Sometimes you know they said that if you look at you know the Sylvian fissure, you don't have to measure, right? So of course you know the measurement is sometimes you know it takes time. However, here you can see the both image. Here, you know, the 24 weeks of gestation here and here, both are from the same brain volume with a different height. So, you know, it is a brain sensitive. So you have to think about that, and then you can look at the Sylvian fissure. Now, the parietal regions are simultaneously, you know, observed like this, you know, that if you are looking at the 3D transvaginal sonography, you know, you can see in the sagittal section also. Now, the next one is the medullary veins. That here you can see this is the medullary veins, and here the medullary veins at 20 weeks of gestation. And what is the medullary veins? You know, there was a very good article, you know, from Japan, and the Professor Okudera published this. You know, within that, you know, there was a fetal, you know, aborted fetus brain, and here you can see there are the subependymal veins here, and there's a deep medullary veins from the ventricular zone toward the brain surface. And at the same time, you know, the superficial medullary vein is running from the surface of the brain towards inside. And then there is an anasmostic medullary vein. Because of this, you know, anasmostic medullary veins, you know, superficial medullary vein and the deep medullary vein shake hands. Okay, so here this is the 16 weeks, you know, the medullary vein, and 18 weeks and 21 weeks of gestation. It is longer, right? And 24 weeks of gestation and 25 weeks of gestation, much longer, and 30 weeks of gestation. The number of the veins are increasing. Now, those are the development of the medullary veins, and then sorry, and this is a 3D slow flow image between the 18 and 30 weeks of gestation, and here you can see the superficial medullary vein and deep medullary vein connect, most probably due to the anastomosis veins, almost at 25 weeks of gestation. You remember the Sylvian fissure became rectangle at 25 weeks of gestation. So 25 is something, right? And in the medullary veins, in cases with the MCD, the over 25 weeks of gestation. Now, because you know before 25 weeks of gestation, it is not connected. So you know we compare the cases with the MCD and control, and here you can see this is the MCD baby, and you can see the very abnormal, you know, premature MCD. And here also, you know, 27 weeks of gestation. This is a partial deletion of the 4P. And also, you know, that this is very short, you know, they're not connected. And this is a microcephaly 5. And this side, this is abnormal. This side is normal, right? And this is a tendinopathy. And here, this is also, the unilateral abnormality is seen in the medullary vein angiostructure. And sometimes, if there is a MCD, we can see the very normal looking of the medullary veins. However, that we have the significant difference between the control and the MCD cases. Now, lastly, the cat ear line. What is a cat ear? Here, for more than the 20 years, I have noticed that, the diagonal echogenic lines outside of the lateral ventricles in the anterior coronal planes of the fetal brain, like cat ears. And in addition, we notice a missing linear structure or different shape of the cat ear line in some cases of MCD. So, we had the research on the cat ear line, and the basic coronal plane on the orthogonal view was determined for the CL evaluation, cat ear line evaluation, and exactly the same as, exactly the same as for the Sylvian-Fisher angle. And here, this is the normal CEL appearance. And first, no visible CEL. And the next one, only inside the subplate, that is called, we call that pre-CEL. And CEL is created. And then thereafter, the CEL is continued to exist. And here you can see the changing appearance of the no visible CL to pre-CL. Then CL was observed between 16 to 19 weeks of gestation. Now, we compare the control and MCD group, and CL is seen in 98% in control group, while 31% in MCD group, and pre-CL was 60% in the MCD group, while only 2% in control group. In addition, abnormal CL is seen only in the MCD group. And what is the abnormal? The sometimes, persistent pre-CL, or, the abnormal CL like this. And this is the summary slide of our speculation of the normal and abnormal CL development. And from our study, we can say that in normal brain development, no visible CL changing into the pre-CL and then the CL by 19 weeks of gestation. And maldevelopment CL is summarized here. Of course, we had 31% of the MCD cases with normal appearance of the CL. However, delayed CL or persistent pre-CL and abnormal CL may be accrued to find cases at risk of subsequent MCD. Now, we found that, the cat ear lines are shown in different locations, depending on the probe angle as shown here. So here you can see this means that the CL is a line that is always perpendicular to the ultrasound beam. So we can say that cat ear lines are serial radial lines that exist continuously on the coronal section. So here you can see the radial lines are observed in the both hemisphere in all continuous coronal planes from anterior to posterior. Can you see that? Yes? Okay, so this means the cat ear lines are not only in a specific coronal section, but they are radiating throughout the entire brain parenchyma. Here, is a histological finding of the normal case of ours, but CL is never visible in any microscopic view. And also, this is from Gregor Kaspian. He is the boss of the Christian Mitter. And however, the Harvard MRI, even Gregor cannot find any CL on the MRI images. Now, we can say that CL is only the ultrasound, the ultrasound specific findings. Now, what is the CEL? CEL represents the neuronal migration tract. Oh, okay. However, the migration towards the pia mater of the brain surface from the subventricular zone. However, the pre-CL is in the subparate, and CL is a subparate plus intermediate zone. It means, the migration is this direction, and CL is like this. So, oh my gosh, this is completely opposite. So, is our hypothesis wrong? And then I found the article that this linear structure might be the medullary veins. It says that deep medullary veins. So we look at that, the pre-CL and CL. And if there is a medullary vein, oh, that is my field, right? And then I thought that, that most probably, the medullary veins here, the superficial medullary veins there, right? And then here is the premature venous plexus, for a later deep medullary veins. And then, the growth of the superficial medullary veins, most probably, this might be the pre-CL. And then after that, because of the anastomostic medullary vein, they are connected. Superficial and the deep medullary vein connected, right? Shake hands. And then it might be the pre-CL is the superficial medullary vein, and the CL is the superficial plus anastomosic plus deep medullary veins, right? So it makes sense, right? However, time lag of the neurosonography depiction between the CL and the medullary veins. Here, this is at 23 weeks of gestation. Already, the CL is clearly seen, right, in the subparate and intermediate zone. However, still at 23 weeks of gestation, that is before 25 weeks of gestation, right? And the 23 weeks of gestation, the medullary vein, still, they are stopping at the border of the subparate and the intermediate zone. So how can I explain about that? Most probably, the pre-CL changed into the CL at around 17 weeks or 18 weeks. And then, however, even when the CL becomes visible, the slow flow images still show only the superficial medullary veins within the subparate, right? And the Mars medullary veins throughout the subparate and the intermediate zone are visualized from around 25 weeks of gestation. Most probably, that this delay may be due to the limitation of the Doppler resolution, or the first, here the deep medullary vein is super small and super slow, right? Therefore, even by the slow flow Doppler image, that super slow flow cannot be detected. So most probably, but it might be resolved, in the future because of some technical development. Now, so this is my last slide. Don't rely on too much indirect signs. It might be the false positive. So, if you have any suspicion of having MCD, genetic test, including the exome sequencing, is a must. And the serial scan after that, not, I don't recommend, the every week. However, the every week or every 2 weeks, the serial scan is also a must. Thank you very much.
Mitsuko, I have I think perhaps a quite easy explanation why you don't see the veins is related to something called cosinus. Cosinus. There are sinus and cosinus. In the equation of Doppler, you have something called cosinus. As if you come 90 degrees to a vein, you will see no flow because the cosinus eliminate is you multiply by f by 0, 90 degrees. Cosinus, okay. Trigonometry, you know trigonometry? Trigonometry, sinus, cosinus, tangential.
Angles.
And this is why you don't see it. And
No,
this is
actually, that is a slow flow. That is the more powerful one with the power Doppler.
But the moment that there is in all your images, you see very nicely those that come perpendicular, 100 degrees, but when you come at 90 degrees, there is no flow.
You mean this direction? Yeah, of course, it is quite difficult, to demonstrate because of the aliasing, the color Doppler, power Doppler. But I think, the measuring vein is not the perpendicular one. Of course, that there are, the many, the radiation like the structure. Therefore, Gustavo, therefore, that is not the, the veins, there are many veins, from all over the cortical plate to here. So, the demonstration is like here, but, there are, of course, that there are the blood flow there. Katia line. The microphone, please. Yeah, actually, the Katia line also, as I showed you, that is a perpendicular of the beam, the ultrasound beam, right? Therefore,
when you don't use color, you see the interlying between the pia, within the pia and the epicogenic vein. Okay, so you see it very nicely. And you don't see very nicely those that come from upside because you come 180 degrees. Mm-hmm. So without color, you don't see. The moment that you put color, you see much better those that come in this direction. This is very simple.
Yeah. The other point is that when a deep medullary vein comes from the surface and penetrates inside, together with it, it drags the sleeve of pia matter. And pia is very reflective. And that is why you see them as those, brilliant spectral reflectors at the two areas. The pia matter is reflective. So I think it's not only the venous walls, but also the pia matter which comes in as a sleeve around the vein.
Maybe, that we can see. Thank you very much.
I'd like to invite Professor Mullinger to speak on diagnostic features of fetal MCD in USG.
Okay, so thank you again for the introduction. We are going to speak about malformation of cortical development, but will be probably an introduction because it's impossible to speak about all the whole issue in 30 or 40 minutes. Okay, we need to have some disclaimers. In most of the cases, we were not able to diagnose this kind of malformation because many of them are not seen early in pregnancy. So in some cases, if you are very astute or have a lot of luck, you will be able to make some diagnosis, not all of them. And the second important issue is that the cases that we present usually are cases that are diagnosed by very experienced operators with special interest in fetal neurology. Almost all the cases that we see are referrals. There is someone else that see that something is wrong and say the patient to you. There is not fetuses. Most of them, they are not diagnosed during scanning procedures, but during detailed examinations. And we don't have much data regarding the cases that we don't diagnose because only the SUTAs in a medical legal problem we know that we missed. Eventually, neural proliferation occurs between 2 and 4 months of gestation. Migration occurs between 3 and 5 months of gestation. This is from Volpe. So eventually, from the theoretical point of view, it starts developing at this time, but not always what it's happening in the brain you can see when you perform the examination. So in most of the papers, people say that these kind of malformations are not detectable before 20 weeks, and everyone knows that fetal MRI is the preferred technique for diagnosis. And you can see this paper was published in a very, very prestigious journal, Brain, came from France. They have a lot of cases with neuropathological confirmation of cobblestone lissencephaly some years ago. And this short sentence understand what people think about early diagnosis of malformation of cortical development. In fetus, despite performance of prenatal brain imaging, argyria, pachygyria would not be discussed with one diagnosed before 22 weeks of pregnancy because cerebral hemispheres are smooth until 20 gestational age. Later on is a paper in 2012 by the group of Andrea that they study fetuses between 15 and 24 weeks at a mean gestational age of 22. There were 30 patients. 27 of them were referred because of or were seen because other associated anomalies. Most of them they were agenesis of the corpus callosum or some cases of insults. Only 3 brains were considered normal by ultrasound. So, and they wrote, because it is already clear from current clinical practice that MRI is far superior, at least before 24 hours, for the diagnosis of these conditions. So the purpose of their paper was not to compare. And these were the images they published in 2012. I think perhaps today they will be able to produce better images, but you see the shape, the abnormal shape of the cortical surface, and in this way they were able to make the diagnosis, at least suspect malformation of cortical development, and in many of their cases they have also a pathological confirmation. Another paper that came from the United States is a fetus at 23 weeks, and they were able to diagnose this kind of malformations quite clearly using the MR. In 2007, we published a paper of 23 fetuses with malformation of cortical development. Most of them were also confirmed by a pathological examination. The mean gestational age we made the diagnosis was 26 weeks, but we have some cases quite early in pregnancy at 18. So my message will be at the end of the lecture that in optimal condition, the structure of the brain may be demonstrated by ultrasound. When you perform an examination of the fetal brain, you should remember that the brain development is dynamic. There is no brain structure that cannot be depicted using the appropriate technique at the correct time. And yesterday, Prashant showed us how he can demonstrate the limbic system. That is something that I think that is something most of us consider that it cannot be demonstrated, but ultrasound, you show that it's there. We can demonstrate the hypothalamus. We can demonstrate every structure, the chiasma, the optic nerve, every structure that you know what to look for, you will be able to find it. Now, if I show this image and say, will it be possible to make a diagnosis in this case when you have a normal lateral ventricle, you have a normal cerebellum, and you have a normal measurements of the fetus, and even if you use not exactly axial planes, you will see that it's apparently normal. But the moment that you put a transvaginal ultrasound, you see something that is at least suspicious that something is wrong. And what you should look, first of all, is that interhemispheric fissure is not straight. Okay, there is a pattern of the one hemisphere is going in the other one, so the interhemispheric line is not straight. And here you have another one. Also, you see that the lateral ventricles are asymmetric. The frontal horns are very particularly asymmetric, because in this case, even you don't see the lateral ventricle, and here you see one that is higher than the other. But what is important that you should be able to recognize is that interhemispheric fissure is not completely straight, and these cases, both are cases of tubulinopathies. Now, until now, and the literature says that all the cases of tubulinopathy have neurodevelopmental problems. And there were actually very few reports saying normal or almost normal persons with tubulinopathy. In our series that we published this year in 2023, half of the patients have one of the parents that have tubulinopathy and were considered normal until we make the diagnosis in the fetus, we make the diagnosis in the mother or the father, and when you start doing a neurological in-depth test, you will see that most of them have some problem, but they are functioning normal. And you should remember when you say that something is abnormal in the brain, you should remember that most of the cases of people that have neurodevelopmental problems, the imaging is normal. So this means nothing. But this is the way we are able to make this diagnosis. This is quite late. It's at 26 weeks or 27 weeks. So what ultrasound findings should raise the suspicion of malformation of cortical development? Okay, I speak about the interhemispheric fissure, but there are others. If very early in pregnancy, before you know that the sulcation should be there, you see that there is sulcation. In this case, you see at 22 weeks, you have sulci. This should be at least suspicious of a malformation of cortical development. Usually, these fetuses, you will see associated malformation. It will be very rare to have a fetus that have a malformation of cortical development that have nothing but only one finding. But you see this sulci. This means that something is abnormal. Or in the other side, you see a fetus late in pregnancy that has a completely lissencephalic pattern. You should suspect that something is wrong. Now, if you are not sure, what you do is, or you have your atlas, as I told you yesterday, or you look at the same patient at the same gestational age, and you see how they look. So you have a normal one, so you understand clearly that this one is abnormal. And the same here, you have at 28 weeks, a completely lissencephalic pattern is most probably something is abnormal. Sometimes you will see sulci. You will see the sulci that are very deep and they have a lot of fluid inside. It means or that the fetus is macrocephalic, and in these cases you can see a lot of fluid inside. But many cases this is because the brain is is small. And so you need to, the next thing you need to do when you see something like that is look at the head circumference. And you have a head circumference that is big, most probably this is normal. But if you have a big head circumference that is small, you should suspect that there's a lot of fluid around the brain. This brain is abnormal. And again, this is an easy case when you have a very smooth and thin cortex. There is almost not cortex. There's a lot of fluid around the brain. This is for sure abnormal. Now, many patients, what we see is that there is not only the surface of the lateral ventricle is abnormal, or only the surface of the brain, but you see something is some parenchymal. The whole brain is affected. Okay, you see also early appearance of sulcation, abnormal sulcation, and a deformation of the wall of the lateral ventricle. Will be always abnormal. Or when you see a very irregular cortex with a serrated pattern, this is another case. The brain is very symmetric, and this another thing that I learned from Daniela and the MR, that the brain, the hemisphere are usually asymmetric. So if you see something that is very, very symmetric, you should suspect that something is normal. It's a lot of fluid around. And another important thing, if you look at in detail, you will see here that there is an abnormal sulcus. Okay, when you see a communication between the subarachnoid space and the lateral ventricle, this is schizencephaly, open lip. Here you have the presence of cortical nodules, tuberosclerosis. We are going to develop the issue of cortical nodules and tuberosclerosis in a few moments. Here you have an abnormal shape of the corpus callosum. That is a subtle finding that also can not necessarily be associated with malformation of cortical development. And I'm going to show you also this case in more detail. Sometimes if you feel current understanding and you see something like that, you see, no, it cannot be an heterotopia, because heterotopia should not be present so early, because it has not been described so early. Sometimes you will be able to see heterotopias very early in pregnancy. They are there. Now, it is possible to reach etiologic diagnosis based only in ultrasound. Yes, sometimes it is possible. Let's speak a little bit about cortical hamartomas of tuberosclerosis. For those that are not in the field of pediatric or neurology, to make a diagnosis of a clinical diagnosis of tuberosclerosis, you need to have some of the major findings or some of the minor findings. The fetal diagnosis is based in the presence of definitive diagnosis when you have two major criteria. Okay, that the major criteria are the presence of cortical tubers, either subependymal or an astrocytoma, the presence of rhabdomyomas, or in the kidney the presence of an angiomyolipoma or the presence of cyst. Minor are non-renal hamartomas that are extremely rare. So you are able to find two major. In the case of the fetus, usually is cortical tubers and rhabdomyoma. You make a probable diagnosis is one major, one minor, or when you have multiple rhabdomyomas. If you have a heart that is full of rhabdomyomas, most probably the diagnosis is there. And possible if when you have one major, that usually is the presence of one or two rhabdomyomas that you are not sure, or the presence of a single tuber in the brain. Now, these are images for our publication also the last year, and this is a fetus at 16 weeks when Dr. Brusilov, one of our physicians, realized that here there is a rhabdomyoma, probably a rhabdomyoma. At this time, the brain was completely normal, but thanks to the possibility to make an exome or to look for one of the two genes that are associated with tuberosclerosis, we reach a very early diagnosis. But you see, they may present in different shapes. There's in some cases even it can obstruct, as in this case, the aortic outflow. And here you have again a very florid cases. You need to remember that after delivery, rhabdomyomas usually disappear. So the possibility to make the diagnosis is in utero. Again, until now, until this case, the early diagnosis was done in one case in South Africa at 20 weeks. Usually they appear, you perform an examination at 22 weeks, everything is normal. During the third trimester, you see the presence of rhabdomyomas. And this is an example how they look when you perform a live examination. In this case, at 25 weeks, it was well before the possibility to make genetic analysis. It was in 2009. Okay, and when we look at the brain, we were able to reach diagnosis based on the presence of a single small tuberous here. Now, and here you see the cat ears. Okay, yeah, they are there. But by the way, but this is the tuber, and actually the advantage of ultrasound in these cases, as when you do we do the examination, is a live one, and so you scan the whole brain, so every small findings will be able to see. With MRI, when you have cats, probably you will find this tuber, but probably not. It depends where the cat is. And now this is another case again. Before we had the possibility to make a genetic diagnosis, but this is a fantastic case because it was a refer case. The diagnosis was made in another hospital, and they were rhabdomyomas. And the ultrasonographist, and now is the director of one of the units in Israel, she was completely sure that there is a tuberous sclerosis. So she referred the patient for MRI, and the MRI wrongly interpret there were so many that wrongly interpret as normal. And only when we review the images, it was possible to see. So it depends, again, it's not the MRI, it's the person that makes the interpretation of the examination. But for us, it was very clear, very florid case. So, with the collaboration of also of one of the participants here, Dr. Prabhu, we put together a good number of cases, and we were able to see what is the pathological finding, and how it can be seen. It can be seen in ultrasound. The white matter lesions that are very rarely seen in ultrasound appear as an echogenic or very low echogenicity when you compare with the surrounding parenchyma. Subependymal nodules, and I think that yesterday Ravi showed one case with a subependymal nodule. Again, subependymal nodules are much better seen by MRI than by ultrasound, but we were able to see, if you know what to look, because the echogenicity is similar to the ependyma and the periventricular white matter. Sometimes you can see calcification, but they are difficult to be diagnosed. The cortical subcortical tubers are the one that I show you, these big patchy white echogenic lesions, and subependymal giant cell astrocytoma. There is a case by Dario where he showed a tumor, a periventricular tumor. They are solid, and not always they are present because usually they appear later on in life. Now we move to hemimegalencephaly. In the cases of hemimegalencephaly in neurocutaneous disorders, this is again extremely old. I think it was in years ago with the Elsin machine. This is the first case. It was quite clear that this is a case of agenesis of the corpus callosum. The interhemispheric suture is continuous. There is no corpus callosum. Okay. There was a connection, but eventually it turns out to be a normal vermis. But when we look at the hemisphere, this was the shape of the hemispheres. So it was very clear that something is wrong. Okay, and again we compare with the normal, and we know that something is wrong here. But as I told you yesterday, when you see something wrong, don't forget the brain and start looking at the fetus. But because after delivery, it turns out that they have a preaxial polydactyly and a very what's called a forme frustrée of cleft lip. It's a very small cleft lip that is present. It's a case of hemimegalencephaly. And when we look at the pathological specimen, you see how different both of them are abnormal. They have this abnormal sulcation, but both of them, and there is a difference in size. Now, if we move from proliferation to migration, okay, we start thinking about the possibility to make lissencephaly, in this case Miller-Dicke lissencephaly, by a paper by Fong and Toy from Canada in 2004, and they were very clever. They did nothing complicated. They performed transabdominal ultrasound examinations. Okay, most of the patients were referred because of mild ventriculomegaly, and after the children were born, and the diagnosis of Miller-Dicker, they were, most of them were Miller-Dicker. They went back to the images and they realized that at 23 weeks there was not parieto-occipital fissure, and the Sylvian fissure was very, very shallow. And this is a case in 98, and I turned out to this case because it was a medical legal case, and by one of our best sonographers, the teacher of all of us, and the patient was followed because very mild borderline ventriculomegaly. But at this time in 89, no one was looking what we are looking today. And at 22 weeks, you see the shallow Sylvian fissure, and here again you see the shallow and the absence, almost complete absence of the parieto-occipital fissure. And it turns out postnatally that it's a case of Miller-Dicker. Cases of extreme microcephaly with a simplified general pattern are straightforward, and this is how the children look after delivery, and you see that there is something that is quite useful to make a diagnosis of. You are not sure if microcephaly or not. You should take a ratio between the distance between the upper part of the nose, okay, and the chin, and compare with the size of the brain. This should be, in a normal children, should be more or less the same size. If you see something very, very, very small, and you can confirm that by measuring the distance from the base of the cranium to the bregma. Again, you understand that something here is very wrong. And when you see the children, he does not have a big ear, but a very small brain, or calvarium. Cobblestone complexes. This is a very early diagnosis at 14 weeks and 6 days. Okay, we start by seeing that it was polydactyly. The eyes appear abnormal. I hope it will work. Okay, the pattern of the cerebellum was abnormal, and if you look during the video, I will try to stop it in the right place. You look at in the video, you see that the brain parenchyma close to the cortex is hyperechogenic, and this is hyperechogenic and it's very irregular because the neurons went through the glia membrane and are placed inside the meninges, and this is very characteristic of Cobblestone. And now we took also 3D, and you see the very abnormal shape of the vermis with a large cisterna magna and a large fourth ventricle with the characteristic Z shape. And again, here you have the same fetus, the abnormal normal borders of the lateral ventricle, the abnormal size, and the quite few fluid around the brain. So what we did this time, we put in the list post-axial polydactyly, cataract, coloboma, probably, ventriculomegaly, meningocele, was also small meningocele, abnormal cerebellum, abnormal brainstem, agenesis of the corpus callosum, malformation of cortical development, and at this time, before the possibility to have exome, but we had the possibility to look for autosomal recessive disease, and there were two possibilities based on these HPOs. This was Joubert syndrome, Meckel-Gruber, because the presence of all these findings, and this was associated mostly with this mutation, or the possibility of Walker-Barbour with a mutation in the POMT1 gene, and actually it turns out to be a mutation in the POMT gene. Both of them are autosomal recessive disease, but they look quite similar. And here you have another case. When you see very severe ventriculomegaly early in pregnancy, you should think about Cobblestone. And here you see the eyes, there was cataract, the shape of the lens were abnormal, also the cisterna magna was abnormal, and again a case of recurrent ventriculomegaly. I have another 10 minutes thanks to Prashant. Thank you. This is something that is very dangerous. You have a patient that come to you and say, yes, the previous pregnancy was abnormal because it was severe ventriculomegaly, and we underwent an abortion, and they told us that everything will be okay. And this is the case. It comes because of, again, recurrent ventriculomegaly, but what we realize is that the brainstem had the quinquet or set shape, okay, and also you have here retinal detachment. You see inside the eye, you have retinal detachment. So you need to look for polydactyly, and you find polydactyly. Most probably this is not recurrent ventriculomegaly, but it's recurrent Walker-Barbour. Heterotopias, okay, and this is a case, the patient was referred because of mild asymmetric ventricles, and we were lucky to see the presence of multiple nodules. It's a case of filamin, and always you should ask the mother if she went on an MRI or she have any epilepsy or other problem, because in most of the cases, if it's a girl, it can be filamin. 40 weeks of pregnancy. The patient was referred Friday afternoon because of huge arachnoid cyst that was seen in a routine examination. The patient underwent an MRI, and they saw the cyst and say, okay, we are going to treat you after delivery, but they come after the MR, and we saw here that the sulcation was abnormal, and what was very strange is the shape of the lateral ventricle with the presence of the periventricular heterotopia. So we look back at the MR, and here you see again the presence of pachygyria, periventricular heterotopia, and yes, there is a cyst, and there are reports of the presence of these conditions of periventricular heterotopia associated with cysts in the arachnoid, in the infratentorial arachnoid cyst, retrocerebellar, but also it turns out that they can be also arachnoid cyst in the supratentorial structure. The corpus callosum was normal, and the family in Israel, you can perform late abortion, opted for termination, and again you see here the remains of where the cyst was, but you look at the brain, you see how different are the hemispheres, and you see here the presence of what was called at this time pachygyria. Some cases are very easy to diagnose because those fetus have multiple malformations, and this is the abortus. But I am putting this case here to show you what is laminar white matter heterotopia. You see here is the presence of neurons where they should not be. This is the white matter, and the presence of polygyria. Why is called polygyria? Because they are like sulci and gyrus. But what is characteristic of polymicrogyria from the pathological point of view is that these pseudogyri, pseudosulci are not covered by meninges. There are no meninges. In normal sulci, you need to have pia and one of the on the arachnoid going in, and here they are not present. So this is polymicrogyria, and Andrea showed you today another case of polymicrogyria from the pathological point of view. So remember, this is what we speak when we speak about heterotopia that is not periventricular and polymicrogyria. Now, which ultrasound findings should raise the suspicion of very early malformation of cortical development? Okay, again, I think that yesterday Ravi showed these cases. There are different fetuses early in pregnancy with the presence of very early parieto-temporal sulci and gyri, and they can be seen clearly. You don't need to be very clever, because usually the patient come to you because there is a very severe thanatophoric dysplasia, the bones are short, the chest is small. So, but look at the brain, because this makes the diagnosis of the FGFR3 type of malformations. There are not pathognomonic of thanatophoric dysplasia. Also, someone told you that they can be associated with other skeletal dysplasias. Now, it's possible to see that early in pregnancy. Here you see we can see a fetus at 13 weeks, and you see here that this zone, the lamination is completely abnormal, so it can be suspected, but the pathological sulci are not still clearly demonstrated at this gestational age. This is cases at 14 weeks and 4 days, and you see, as was shown in the MR, when you see that there is hemispheric asymmetry. It's not asymmetry of the ventricle, but asymmetry of the brain parenchyma. And here, one side, you see that it's quite thin, but the border is completely regular. And here you see the irregular border on the other side, and the parasagittal plane, you see exactly the same. Now, we are able to see the cortex early in pregnancy, and it can be seen with a good machine or an extra good machine during the first 20 weeks of pregnancy. As pregnancy goes up and the sulci disappear, it's much more difficult to see the cortex. But here you have the cortex is normal. This is the subarachnoid space. Here you have the pia. This is the cortex, and this is subplate, a periventricular zone. Okay, this is a patient at 14 weeks and 4 days. I don't need to speak a lot, too much to show you or that you understand that here the cortical layer is absent, is abnormal. So you don't see the cortical layer. This is a very early sign that something is wrong with the cortex. Okay, and in this patient, again, you see this irregular serrated pattern here. Okay, this is This is another case at 15 weeks. Again, you see here you don't see the cortical layer, and when you look here, you see the cortex is present, but there is a very early presence of an abnormal sulcation. And when you move the probe a little bit, what you see? Nodules. 15 weeks and 5 days. This patient was referred because a second opinion, because a keyhole shape of the fourth ventricle earlier in pregnancy. We saw the patient at 19 weeks and 5 days, and the only structure that was normal was the cerebellum. And this is the image, one side. And look at the other side. Look at the occipital body. What happened in the occipitum? You see, something is missing. So these were the still images. And this is the case I show you, early presence of heterotopia. This is one of the few routine examinations I did, and I found something. You see here these two small lobules. I say, no, it's not possible. They cannot be there. Perhaps it's some kind of bleed or something like that. I called the patient back in 2 weeks, and they were still there. And look how difficult it is to see, because if you move, you may miss them. Hop! And we call, again, I was not completely sure, so we called back the patient at 21 weeks and 2 days, and now we start seeing something that is very characteristic, the quadrangular shape of the lateral ventricle and the presence of the irregular pattern. It start to have ventriculomegaly. The corpus callosum was apparently normal, and this is the image at 21 weeks. It's much clearer. Again, it can be missed. Since then, we have a lot of cases. Later in pregnancy, they have this irregular pattern of the lateral ventricle. Early in pregnancy, at this gestational age, is a sign of developing heterotopia. And we published this again in 2023, showing these cases with the different diagnoses of malformation of cortical development. And again, look at this one. You see how echogenic is the zone of the subplatant cortex, and this is with abnormal vermis. This is very, very highly suspicious of cobblestone. In conclusion, currently available ultrasound and MRI equipment enables very good visualization of the main brain structures, including the cortex formation. Malformation of cortical development can be diagnosed in utero with dedicated neurosonography or MRI. Early diagnosis is based on a careful search for anomalies, and these anomalies may be very subtle. The ultrasonographic finding that suggests an early diagnosis of malformation of cortical development, the presence of abnormal overdeveloped sulci in relation to gestational age, small abnormal gyri, irregular ventricular margins, symmetric hemispheres, callosal anomalies, and associated findings mainly in cerebellum and the eyes, and also in the genitalia. Thank you very much. But I have another one. This is a patient that was referred to us after 2 terminations because of severe malformation at 15 weeks, and we were asked to look for signs of microcephaly. We did the measurements, and everything was normal. 15 weeks, everything was normal, but if you look carefully, you will see that something was not so nice. It was the HCAC radio that actually was normal for the wall gestational age, but usually early in pregnancy, the ratio HCAC is much more in favor of a large ratio. It's 1.2, 1.3. And this is the ultrasound. When you look at the ultrasound, what was clear that there is too much fluid around the brain. The early in pregnancy, the brain, the hemisphere should touch. If you have fluid, you should suspect. And here I put one to compare how big is the difference. This is normal at 15 weeks. You see that the hemispheres are very close one to the other. Here you see a lot of fluid, and you see that the occipital lobe ends here. A lot of fluid in the anterior portion of frontal portion of the brain. This can be normal. And when we look back at 17 weeks, okay, you see again the same findings. The HCAC ratio was by now abnormal, so we reach a diagnosis of the same disease that in the previous two patients. Thank you. Now I finished.
Thank you, sir. Thank you for the wonderful lecture. Now I'd like to invite Dr. Darinia Pryor for the diagnostic features of fetal MCD with MRI. Over to you, ma'am.
Well, being the third speaker talking about diagnostic features of MCD, I will not be able to present you something new. The big difference between the previous speakers and me is that I will have a mostly unscientific approach and just show you things you might use in your daily life, or just show you another vision that might be interesting or not. It will be short. Well, postnatal morphological signs of MCD are very often not completely applicable in prenatal stages, but fortunately, Professor Regini published a paper where we have an approach to prenatal morphological signs of MCD, and I would really recommend use this approach because it will help you to classify anything that you can see on MRI. We already heard MCDs are more frequent in male fetuses. They very often have a small brain, and in more than 50%, they are associated with disorders of commiseration. However, I will not talk about the classification. I will try to find features that may point to a perhaps genetic underlying background. We know that mutations may cause impairment of cell proliferation, migration, and post-migrational maturation. Unfortunately, exactly the same features can be produced by infection, toxic events, or vascular events. So that does not help. Mutations in one gene may cause different malformations, and the other way around, mutations in two different genes may cause one and the same malformation. This also does not help. So I asked myself, what may point towards a genetical background? And there are some features that very strongly point towards such a background, and others that may be or maybe not. And I would like to show you all these morphological features. One thing that we have known for a long time are the gradients, as they have been defined by Professor Dobbins already in 1999. And what does it mean? That the changes are either frontally or occipitally predominant, or even a temporal gradient is known. And you see here different cases, gestation week 37, there is an occipital dominant lyssencephaly, as in this case too, and in this case in 36 gestational weeks and later postnatally, you see the gradient, the changes are frontally pronounced. Unfortunately, there are a lot of genes that may lead to lyssencephaly, and there was a paper that said radiological findings could reliably predict molecular results only in Azaria with a posterior to anterior gradient. So if you find a gradient, you know there is probably a genetical background, but it will be very difficult to say which one. Gradients, of course, band heterotopias can also have gradients. This is a case in gestation week 28, and you see here the blue arrows pointing towards lines in the brain, in the coronal and axial sections. And story was the fetus was sent for borderline ventriculomegaly. Seeing these lines, I sent it back to the sonographer and I asked Elizabeth, what do you see? I would not dare to interpret sonographic images, but perhaps you can. What she told me was nothing. Okay, then we went back to our MR images and did some post-processing. That means we did color maps of our FLAIR T2 informations and from the radial diffusivity. And here you see in blue, there are clearly lines on both sides, more on one than the other side. And so a termination of pregnancy was done. And here you see the postmortem MRI. And this was the histology proving our suspicion of band heterotopia. As Gustavo already showed, premature abnormal gyri point towards a severe MCD, in this case, a muscle eye brain disease that we saw at first in gestational week 22. And if you use Regini's classification, that would be a wart. Is that true? Yes? This on the black side here, and then you see the wavy cortex in gestational week 25. And this is the end stage of muscle eye brain disease. On the right side, you see a upper syndrome that we saw at first in gestation week 24 and with the full-blown polymicrogyria in gestation week 30. I don't comment on that because you saw that now twice. However, sometimes it's not so easy because you get these fetuses late in pregnancy. And the brain looks almost normal, but if you look here, there is a sagittalization of the parahippocampal sulcus and also postnatally. And in FGF3 mutations, they can also be just a chondrodysplasia. You see the profile of this child. And sometimes the only prenatal sign is this sagittalization of the sulcus. We call that a focal dysgyria. What about dysgyria? Also in our case with the band heterotopia, we saw it because there were very shallow sulci. On the left side, the case in the turquoise frames, it is a normal fetus. And you see there is a very shallow sulcation and there was an abnormal symmetry in the temporal lobes. And also the calcarine sulcus was very shallow. So if you are not sure about a singular finding, you have to look in the brain whether you find other things that may point into a certain direction. Of course, the persistence of transient structures is a sign that something goes wrong. If the germinal matrix is still in its original region, then the neurons will be missing in the periphery. And we see that in a lot of dyscencaphalase. In the lower row, you have age-matched normal cases. And here you can see this with a pathological specimen, but of course you will not only look at the persistent germinal matrices, you will look at the brainstem, but I will come to that later. When you are not sure whether you look at the ganglionic eminence or not, you can perform tractography, or Christian can perform tractography, because the ganglionic eminences are gray matter, but they consist of pseudofibers. And so you can prove that this is really the ganglionic eminence and not another structure. That might be important here, just the histology, why you can perform tractography, because there's a directional pattern of the vimentin positive structures, and that's why you have pseudofibers where you can perform tractography. This is a case in gestational week 29. you see the germinal matrix is still there. It should not be there because the normal fetus on the right side doesn't have it. But is it really the ganglionic eminence, or is it a giant cell astrocytoma? Is it hemorrhage? Well, when you perform trachrography, you can prove that it is really the ganglionic eminence. And this is, again, this fetus in gestation week 32 compared to a normal case. And this is the outcome. You see there is, the face looks bigger than the brain. And there is still a persistence of the ganglionic eminence. And there were therapy refractory seizures, and the cortex is somewhat simplified. So it is a mild form of microencephaly. Of course, the germinal matrix, the ganglionic eminences, can be destructed prematurely, and we see that very often in metabolic disease. Here it was a pyruvate dehydrogenase deficiency, and this one is another mitochondriopathy. And here we could do a 3D reconstruction, and you clearly see that the ganglionic eminence is smaller than in age-matched normal cases. Here, the dysplastic brainstem, I don't tell you something new. You have seen that already several times. What does it mean? It is dysplastic. It has preserved the embryonic form that should be gone in about gestation, 16 gestational weeks. When you see something like that, regardless what it is, the prognosis is bad. Of course, the brainstem can also just be small, the pons flat. This is mainly seen in tubulonopathies, but not only. But if you suspect a tubulonopathy, you should look at the brainstem. Well, symmetry. Symmetry is very often associated with lissencephaly, but there are also situations where you have asymmetric findings, as for instance in hemimegalencephaly or in Aicardi. Now you will say, well, Aicardi, there is no genetic background. Well, I can only say not yet, because it is strongly suspected that the genetic background of the syndrome will be found soon. The Cillian fissure, we have heard about the Cillian fissure and its importance already from Ritsuko, but of course the flat Cillian fissure contributes very much to the brain shape. And this is a strongly scientific concept that we coined several years ago, toast brain. And if you see a brain like that with a flat Cillian fissure and where the temporal lobes usually are much wider than the frontal lobes, this is a sign that the brain development is really very abnormal. And of course, you look for other signs of a genetically determined syndrome. These ultrasound images were sent by Marek Scheuss from Estonia. He also spent some time in Israel. He's a wonderful sonographer. And I told him, Marek, I can see the diagnosis from your beautiful images. The irregular midline, that we already saw from Gustavo, the distorted white ventricles with the irregular ependyma. And he also showed the overgrown vascularity of the medullary veins, abnormal Cillian fissure and cingulate sulcus, pontocerebellar hypoplasia, and short corpus callosum. So what can it be? A tubulinopathy, but still he wanted to have an MRI. Well, this is the MRI, and here you really see what informations ultrasound can give you. You would not have needed the MRI here. The only information that we could add was the pathological formation of the basal ganglia, which is also a hallmark of tubulinopathies. Let's stay with this. Similar finding in relatives are always helpful. This case was not the first child. The first child is this one. This one was 6 months, and now you can compare the features of the 6-month-old child with the features of the fetus. And these children have almost everything that Maria Savina described with the European Network of Brain Malformation, what you could find in a tubulinopathy. But still, it is very helpful when you at least ask whether there are relatives that are not okay. And of course, this, Gustavo already showed something. The subependymal heterotopia with the megacisterna point towards a Philamine abnormality. This was the first child. There was an abortion done. This was the second child. In gestation week 21, even if it was MRI, we found the subependymal heterotopia, which was in Vienna. The patient did not go to Israel, so I have to emphasize it was in Vienna, not seen by ultrasound. But in the same session, we took the mother into the MRI, and then this fetus was allowed to survive. Let's talk about the generation of a cerebral cortex. There is a wrinkling and folding, and this is an intrinsic growth pattern of natural systems. It is not only in the brain, and it is, for instance, in Sharp A, dogs. Yes, that's the same mechanisms. And here it is due to an overactivation of the hyaluron synthase 2G. Well, with the help of organoids, this could be copied somehow. And you see there is the mechanical instability that leads to early stages of cortical folding. And you see here the initial wrinkling of the cortex and later the formation of the cortex. And then there was the cell organization of the organoid, very similar to a human cortex. Now, is there a zone that is similar and that triggers secondary mechanical instabilities that leads to more complex folding patterns? Yes, there is a zone. It is the outer subventricular zone, and it only exists in humans. And you will say, well, and how do we look at that? Well, Ritsuko already showed that you can see it, and we are on our way to visualize it with the help of MRI based on our postmortem findings at the moment. The generation of a cerebral cortex, we have the proisocortex, which is the cingulate and insular cortex. This is called the conserved folding, and this did not change much during evolution. The cortex that we humans and also the higher monkeys have results from evolved folding, and there the folds increase during evolution. So the neocortex is a combination of isocortex and proisocortex. This how it looks like. This is the conserved cortex, the cingulate cortex, and I would not call this the lateral fissure. It is called so in this paper, but as you can see, it is the insula. It's not the opercularization, it's the insula itself. And here you have the white-headed lemur with the cortex here and the insula. Then in the chimpanzee, we have already a very developed dorsal isocortex, and this is the human dorsal isocortex. This is how you and I look in the brain, hopefully. And it has found that the evolved folding is the folding within the isocortex. And they also saw that the conserved folding may be less involved in some genetically determined lissencephalies. Well, when I talk of genetically determined lissencephalies, unfortunately, they become more and more because more and more genes are identified. So we don't know whether this is true for all types, but it may be true for several types. Here you can see several fetuses with microlissencephaly, where the conserved folding is really there, and the insula is preserved, and also the cingulate. This also happens in polymicrogyria. Look at this case with the Zellweger spectrum disorder. So this might be regions where it's worth looking at. In contrast, here the conserved folding is destroyed. You see a hemorrhagic process destroying both parts of the brain, both hemispheres, and also the hemorrhage in the region of the midline here. And this is destructive process, probably leads to hydranencephaly. I didn't say this doesn't have a genetic background, but you have to look at other groups of genes, for instance, at the collagen genes that may be responsible for hemorrhage. Well, please use the classification of morphology. It is really important to get a picture of what you are dealing with, and then perhaps consider any signs that you can find to make a most accurate diagnosis. Thank you very much.
Israeli Society of Medical Genetics and Director of Prenatal Genetic Diagnostic Unit at Tel Aviv University.
Hi. Thank you for this introduction, and I'd like to thank the organizers for inviting me to give this talk on malformations of cortical development. I'm sorry I cannot attend physically because of the ongoing war in Israel. The development of the human neocortex is a complex procedure. It is involved with three separate but overlapping functions. First is has to do with cell proliferation and apoptosis. Then the neurons that develop migrate to the various layers. And this is followed by post-migrational organization of the cortex, causing the foldings of the cortex. And malformations of cortical development is a heterogeneous group of disorders disrupting proper cerebral cortex formation. The etiology is varied. It can be caused by genetic etiologies, but also by infectious, vascular, and metabolic etiologies. And the mechanisms are perturbations of the steps that I described before. So it could be caused by abnormal cell proliferation or abnormal apoptosis, be caused by abnormal neuronal migrations, and then could be caused by abnormal post-migrational cortical organization. Now, this is an oversimplified approach, but it's helpful to understand some of the mechanisms that cause this. The manifestation, the clinical manifestations are varied and may manifest as epilepsy in a high degree of cases, developmental delay, various levels of intellectual disabilities, autism spectrum disorders, schizophrenia, and more. The true incidence is unknown because some malformations of cortical development are discovered incidentally by MRI, and some cases are probably never detected. So there's, even in familiar cases, there's variable penetrance. The genetics of malformation of cortical development is quite complicated, and we think that most cases are caused by mutations in possibly hundreds of different genes affecting cell cycle regulation, apoptosis, cytoskeletal structure and functions like the tubulins, neuronal migrations, and intracellular metabolic activity. And I'm sure there are many, many more. Some pathways are known and well described, and different genes in the pathways contribute, such as the PI3K, AKT, mTOR signaling pathway, or the tubulin pathways. But certainly some pathways are yet to be discovered. A little bit about the inheritance patterns of malformation of cortical development, and this may be quite varied. So first, I'd like to make a distinction between germline mutations. These are inherited mutations where the parents have recurrence risk depending on the type. And then there are somatic post-zygotic mutations, meaning that they occur de novo, but not only that, they occur only in certain tissues and in certain concentration. So first, starting with the germline mutations, there are varying types of inheritance patterns. I'll give just a few examples. Autosomal recessive inheritance, where both parents are normal carriers. A good example is the Walker-Warburg syndromes caused by different genes, recessive. Autosomal dominant, a good example could be tubulopathies. Now, true, some may occur as de novo mutations, but they are throughout the body in 100% concentrations. But in some cases, of course, these are inherited mutations. And as I said before, there could be varying penetrance. So normal or closely to normal parent may have a child with a significant MCD nonetheless. X-linked disorders inherited from the mother, like an example of subcortical band heterotopias in female caused by the DCX gene. So these are relatively simple to understand, caused by simple Mendelian inheritance. And the way to diagnose these would be to take a DNA sample, could be during pregnancy, amniocentesis, or postnatally from blood samples. Somatic mutations pose a challenge because they are not necessarily present in all tissues and may appear only in some tissues. In such cases, could be the entire brain or only part of the brain. And these can yet be divided into two different types. So the type 1 somatic mutations, these are gain of function mutations, meaning that one copy of the gene is disrupted, and usually this is gain of function, meaning it causes activation of a certain pathway. And a good example is the mTOR pathways, where activation of this pathway causes overgrowth. And these could be causing megalencephaly and so on. The other type of mutation is loss of function mutation, but this usually requires both copies of the gene to be disrupted. And since we're talking about germline mutation, this happens on the background of an inherited mutation. So a good example would be tuberous sclerosis complex, where the first hit mutation is inherited, but then the tubers in the brain are the result of a second hit, a de novo mutation causing loss of function. So it's important to understand that different mutations in the same gene may cause opposite phenotypes. So this would be like a control case where the sonic hedgehog signaling is normal. Overactivation of this pathway causes overfolding, whereas inhibition may cause underfolding. So this gives you an example that knowing the disrupted gene is not enough. You have to understand by what mechanism this has occurred. So going back to the three different types of malformation, different causes, first talk about some example of disorders of proliferation and apoptosis. So first, if we look at the microcephalies and then the different types, a good example would be a decreased function or decreased activity of the mTOR signaling pathway or the sonic hedgehog pathway. And so this caused undergrowth, whereas cortical overgrowth will be caused by overactive pathways, as I've described before. And this just shows you the pathway and the various different components of this very complicated pathway, including the RTK receptor, and then this activates a downstream gene pathway. Then going over to disorders of neuronal migration, we can give a few examples. then let's discuss the tubulopathies. These are microtubules-associated proteins. There are various types of tubulins, and they can cause various types of abnormalities. This is just showing you the complicated pathway, and the tubulins there are various different types of tubulins making this structure. And then depending on what type of tubulin is disrupted, this may cause problems with neuronal migration, with mitosis, and could further be causing other types of problems such as post-mitotic neuronal differentiation and so on. And then finally, disorders of the post-migrational cortical development. You may have different genes disrupting the axon growth, and then the guidance of which way the axons are developing. And then this is a study that's recently been published looking at brain biopsies of different types of MCDs. And then there are additional pathways that have been discovered and that are associated with this. So we only understand and know, as I say, the tip of the iceberg, because one of the things that has been found was, again, the mTOR pathway, but other genes that are associated have been found to be associated with calcium dynamics, with synapse development, and also with different gene expression. So again, there's still more to be found, particularly because all of the somatic mutations are quite difficult to diagnose unless you have a sample of the abnormal brain. So now moving on to the challenge of prenatal genetic diagnosis of malformation of cortical development, beginning with generally speaking of brain abnormalities in general. So these are quite common abnormalities, and they're thought to occur in as many as 1 in 100 individuals, of course, not all of them severe. And in the past, the way to diagnose them was karyotyping or chromosomal microarray. But if you notice, previous studies have shown that using karyotype or abnormal chromosomal microarray only finds 16, perhaps even less % of cases with brain development, because it is thought that a great majority of brain malformations are caused by mutations in different genes, and these can only be detected by sequencing techniques like exome sequencing or genome sequencing. Whereas if you look at the added value of exome sequencing, different studies have shown a significant increase in the yield of exome sequencing in detecting brain abnormalities. And these are different landmark studies from different years with detection rate as high as 34%, especially in severe cases. We ourselves conducted a large-scale studies, retrospective studies of fetuses with major CNS abnormalities following termination of pregnancies, and all cases were first analyzed by chromosomal microarray. And of the 114 cases, microarray detected abnormalities only in 10%, so 90% were not detected. And these are the different abnormalities. Most of them would have been deletions. There's one case where they're unbalanced chromosomal translocation. So again, copy number variants only account for 10%. And then we look particularly for malformation of cortical development, none of them was detected by chromosomal microarray. Then we went on and we offered exome sequencing to the ones who had chromosomal microarray negative results. And of course, we ended up with 86 patients who were consented, and we had sufficient DNA reserved from the termination pregnancies. And then we were able to detect additional 44% monogenic causes of brain abnormalities. And then if we look into particularly the different phenotypes, found that malformations of cortical development, in these cases, we had 33% detection rate, of course, higher detection rate in complex and multi-system brain abnormalities. Then looking into the different causative genes for the different brain abnormalities, you can see some expected candidates, for instance, L1CAM causing aqueductal stenosis, or the different COL4A genes causing hemorrhage. But then when we move into the malformations of cortical development, again, this is not necessarily only the isolated cases, but cases in which malformation of cortical development was also found in the setting of a complex brain abnormalities. We could see certain some of the expected candidates, for instance, the different tubulins that were associated. But interestingly, we also found a COL4A1 mutation. This mutation is mutation in this gene causes a brain hemorrhage. So it's interesting to think of mechanism where disruption of this genes cause malformation of cortical development. We are reminded so that some of the cases are caused by vascular abnormalities. And then this is a pie chart showing the different types of inheritance. Of course, a lot of them were de novo mutations, but then some had X-linked or recessive with high recurrence rate. And even the dominant cases, most of them had a mildly affected or a completely normal parent. So to compare our study with previous study, we had a diagnostic yield of 44%, an incremental yield over chromosomal microarray. And then looking into this study that was recently published, looking at prospective study and systematic reviews of monogenic condition causing CNS abnormalities in prenatal diagnosis. The study included 30 studies with greater than 1,500 cases. And the incremental yield over chromosomal microarrays is quite similar to our studies. So for all CNS abnormalities, the incremental yield was 32%, and for multi-system 35%, and for isolated brain abnormalities 27%. Now, if we look closer at the different phenotypes and what is the likelihood of making a genetic diagnosis, we see that for holoprosencephaly, posterior fossa abnormalities, midline abnormalities, and absent corpus callosum, the detection rate is surprisingly quite similar, 35%. So we say a little bit over a third of the cases have a clear genetic abnormalities, whereas with isolated ventriculomegaly, even if severe, the detection rate is significantly lower. Then if we look at the detection rate for malformation of cortical development, for all of them was 35. But if we look at the cases with abnormal cell proliferation, the genes that cause abnormal cell proliferation, the detection rate is even higher. So again, this is the way to go forward. And one of our conclusion was to skip chromosomal microarray and to go straight for exome sequencing, because exome sequencing would have also detected the copy number variants, but then it will give you a high likelihood of making a rapid diagnosis. And this just sums up the different studies showing the detection rate of exome sequencing in prenatal detected malformation of cortical development, again showing a significant yield. So when we look at the different genes that are associated with malformation of cortical development, of course, the ones that star high are the different tubulins, and this is from the same meta-analysis showing the involvement of various tubulins. The recurrent cases, again, showing different genes that are associated with the big three pathway, sonic hedgehog pathway, and others. And then, of course, there is a long tail of rare genes that are associated with these abnormalities. And of course, one could imagine that this list will continue to grow, and then that discoveries of new genes will be facilitated. So it's important to go for a whole exome sequencing, particularly when you deal with brain abnormalities, rather than looking at set panels. Just to give you a little examples of the challenge for finding somatic mutation. This is a case that we had worked up with our sonography group. This is a case where late in pregnancy, MRI at 35 weeks showed significantly progressing macrocephaly with abnormal sulcation pattern, abnormal operculation, and also suspected frontal polymicrogyria. And due to the severe manifestations and rapid development, the pregnancy was terminated. First, we went ahead and did germline exome sequencing, and there was this change in the PIK342, which is part of the mTOR pathway. But this occurred in such a low incidence that this passed under the radar of the filters, because this could not have been detected as a cause. And just looking at what we call the BAM file, each one of these gray lines represent a different DNA fragment. And when you do NGS, you actually do parallel sequencing. And then looking at the entire fragment, there were only two of these variants. So this is usually considered like background noise. But then we took a sample from the abnormal brain, and then within the abnormal brain, we found 20% of these abnormalities. So you could actually now see quite a high incidence. And of course, this shows you that these somatic mutations require having a sample, but of course, obtaining a sample during an ongoing pregnancy from an abnormal brain is not a simple task. So somatic mutations such as this are a known cause of hemimegalencephaly, and such mutations could be identified only with the brain sample, and such mutations are predicted to cause overgrowth. And indeed, this particular mutation that we had detected has already been described in the past in similar cases. What is the importance of this? Well, of course, some genes that are disrupted can give you a good example of the prognosis. A lot of them will eventually end up with the patient's decisions to terminate pregnancy. Now, this is an important bit. This is just quite new. The mTOR signaling pathway is an attractive possible target for pharmacotherapy, of course, of pregnancy considered, both to prevent the seizures and counter some of the neurodevelopmental problem. Because this pathway is also important in cancer, certain drugs have been developed to inhibit these components of this pathways, and they have been approved for clinical use in tumors. And an example is everolimus. It's an mTOR inhibitor and has already been attempted to treat Hortin-resistant epilepsy patients that underwent surgical resection in patients with tuberous sclerosis or focal dysplasia. And then the results of treatment with this mTOR inhibitor showed perhaps promising lower mTOR signaling pathway, and this is potential treatment for such cases. But of course, long-term treatments are still required. So to sum up, regarding malformation of cortical development, the diagnostic yield of chromosomal microarray is quite low, 10 to 15%. The incremental yield of exome sequencing in CNS abnormality is high. It's about a third of the cases, and in the malformation of cortical development, it's about 35%. It's important to recognize that there are numerous pathways involved, and that mutations in the same gene, they have opposite phenotypes depending if it's an activating or an inactivating mutations. And then prenatal diagnosis is often not possible for somatic mutations. And I'd like to acknowledge all my partners in this research. So members of the Genetic Institute, our genetic counselors, Vered, Adi, the head of Genetic Institute, Hagit Baris, and entire group of genetic counselors, our molecular laboratory, Anat Bashira, and then our genome centers with Adi Mori, Tal Brill, Sivan, and Alina. And then this cannot have been done without the partnership of the prenatal ultrasound unit, previously headed by Gustavo Malinger and now by Nina Kreiden, with Roy Birnbaum, Michael Brusilovio, Sarah Tube, and many others. And then the imaging department in the MRI unit by Professor Liat Ben-Sira. And I'd just like to end by inviting you to attend the prenatal meeting, COGEN, that will take place May 16 and 17 in Paris. Thank you very much for listening.
Thank you, sir. Thank you for the wonderful lecture. We have time of 1 minute. Any questions for sir? Sir is online.
Hi. Hi.
Any questions? Yeah.
Thank you for a very informative talk. So when you talk about exome sequencing, do you do a trio or do you do only the fetus? Because when we do only the fetus, if we do get a variant of unknown significance, how do we go about counseling the couple?
Thank you for this question. We offer exome sequencing in a trio model. That means examining the fetus in parallel with the parents. The reason for that is when one does exome sequencing, you detect more than 100,000 different variants. And of course, most of them would be considered variants of unclear significance, and it is often required to compare these variants in the parents. For instance, if it's an autosomal recessive condition, you would like to see that both parents are carrier and not just by chance that both variants are present in the same parent. Same for things that have to do with autosomal dominant inheritance sometimes. For instance, we had a case where the corpus callosum was not developed because of a DCC mutation, and then finding this in the parent allows us to go back and check the phenotype, and this gene also causes mirror hand movements, and that were detected in the parent. So having parental information is crucial for diagnosis, especially if you want to get a rapid turnaround time. And in ongoing cases, we often have a turnaround time of maybe a week to 2 weeks at the most. So having the parental sample is crucial for rapid turnaround time.
Thank you, sir. Thank you for your wonderful lecture.